Antiphospholipid syndrome is an autoimmune disorder that you must always consider in your differential with lupus. The nuts and bolts are as follows. Clinically, you hear about a history of a clot or spontaneous abortions in the first trimester. On the labs, there will be lupus anticoagulant, anticardiolipin, or anti-beta 2 glycoprotein antibodies. Here's the thing you'll have to know for the boards. These patients also can have false positive VDRL and prolonged PTT. Remember, even though their PTT is elevated, they are still hypercoagulable because the elevated PTT is an ex vivo effect. In the body, PTT is actually not elevated. What does a positive VDRL make you think? That's right, syphilis. So be careful and think twice, especially in your young women with spontaneous abortions. Let's do a flash quiz. What is the most common cardiac complication in lupus? Pericarditis, followed by Liebman-Sachs endocarditis. Sarcoidosis is a disease that is marked by widespread formation of what classically are described as non-caseating granulomas, whereas the granulomas in diseases like TB are known for their caseous necrotic center. These granulomas in sarcoid appear cleaner, without the same necrotic center. On histology, there are two other important findings: Schaumann and asteroid bodies, which are worth remembering for the exam. So who gets sarcoid? This disease is very common in black women. There are an incredible number of presenting complaints for patients with sarcoidosis, and as such, it's worthwhile to try and get a sense of what all of them are. Nevertheless, in terms of answering step 1 questions, if you see a vignette that describes a young African American woman with a respiratory problem, sarcoidosis should shoot pretty high up on your internal differential. So what's the most important presenting symptom? Restrictive lung disease. Chest x-ray will classically show bilateral hilar lymphadenopathy or reticular opacities. Aside from this, some of the other signs include Bell's palsy, erythema nodosum, and uveitis. Lab findings usually reveal two classic things. The first is an elevated level of a converting enzyme found in the lungs that relates to water retention in the kidneys and maintenance of blood pressure. Can you guess? It's angiotensin converting enzyme, or ACE. The second is elevated calcium level. So why would the calcium be elevated? Because the macrophages in granulomas activate more vitamin D, leading to increased gut absorption of calcium, and thus hypercalcemia. And how do you think this would affect PTH levels? It will decrease serum PTH. One more finding on labs that you may see is an elevated CD4 to CD8 ratio. The management for sarcoidosis is admittedly very complicated, but what you should know is that patients who appear to require acute treatment often benefit from steroids. You will not be responsible for understanding the other intricacies of management. What are the important histologic findings in sarcoid? Non-caseating granulomas. The next disease that we'll discuss is polymyalgia rheumatica, a disease marked by pain and stiffness in proximal muscle groups and joints, namely the hips and shoulders. There are often constitutional symptoms as well, including fever, malaise, and weight loss. So what should you look for in the clinical presentation? A woman older than 50 complaining of muscle pain without muscle weakness on exam. The most important piece of this disease to recognize for your board exams is that it is often associated with temporal or giant cell arteritis. That means that patients may either present with both or have a history of one with a second presentation with the other. Either way, keep the two linked in your head in case they do present together. What physical exam maneuver will help you diagnose temporal arteritis? Palpating the temporal artery. And how is temporal arteritis diagnosed? By getting some tissue with a biopsy. There is no single lab finding that will help you confirm the diagnosis of PMR, but an elevated ESR in an otherwise healthy patient may be a nonspecific sign of inflammation caused by this disease, and as a side note, also of temporal arteritis by itself. C-reactive protein may be increased as well, another general sign of inflammation. CK values are normal, indicating that there is no breakdown of the muscle itself, as will happen in diseases like polymyositis or dermatomyositis, which we will discuss in the next fact. How would you treat both PMR and temporal arteritis? As with most autoimmune diseases, use steroids, namely prednisone, which can change patients' clinical appearance from phenomenal pain to virtually asymptomatic within a couple of days. Fibromyalgia is an interesting disease, and a good one to keep in your differential when you're on the wards. The typical clinical vignette consists of a middle-aged woman who complains of diffuse pain all over her body concentrated around a large number of points, with no apparent physical cause. It's normally associated with several other symptoms, such as stiffness, paresthesia, poor sleep, and fatigue. Why does it happen? Perhaps due to a neuropsychiatric etiology. Because there's no yet agreed upon cause, treatments vary considerably, though some patients respond to antidepressants and anticonvulsants. Likely not to be tested on your step 1. What lab value is aberrant in polymyalgia rheumatica? The general inflammatory markers, ESR and CRP, are elevated. The next two diseases are tough to keep straight. Likely because they're fairly obscure, they sound similar, and they're always mentioned and taught in tandem. I bet you'll definitely see one of these two on your exam. The two diseases are polymyositis and dermatomyositis. Polymyositis is a disease that is marked by progressive symmetric proximal weakness, not pain. Classically, like PMR, it includes proximal muscle groups. How's the diagnosis made? You'll need a muscle biopsy. The biopsy will show perifascicular inflammation and CD8 T cells. Inflammation is around, but not in the muscle fascicles. In your vignettes, look for a younger person with shoulder weakness. In dermatomyositis, the muscular complaints are similar, but the operative change is in the word, dermato, or the skin findings. So what are these nodules called? Grotton's papules, which are classic findings, and there may also be wearing of the hands that's described as mechanic's hands. You may observe a malar rash or a heliotrope rash, which you see pictured here. Do you remember what disease we discussed earlier also presents with a malar rash in many cases? That's right, it's lupus, the great imitator. It's important to know that patients may develop amyopathic dermatomyositis, meaning all the skin findings of dermatomyositis but no damage to the muscles. The muscle damage may start late in the course of the disease, or may never occur at all. Dermatomyositis muscle cell injury is induced by CD4 positive T cells. In a biopsy, you'll see perimysial inflammation and atrophy. Okay, so which would you rather, dermatomyositis or polymyositis? I'd probably pick polymyositis because there's no rash, and also dermatomyositis can be associated with underlying malignancy. As we've discussed, you can make these diagnoses with biopsy, but usually the best confirmatory evidence is actually done by laboratory testing, often with increased CK and aldolase, as well as positive ANA, anti-Jo1, anti-SRP, and anti-MI2 antibodies. And the treatment? You guessed it, steroids, followed by long-term immunosuppression like MTX. Dermatomyositis is associated with inflammation with what type of T cells? CD4 positive. CD8 positive cells are polymyositis. So there are a wide variety of neuromuscular junction diseases, but there are probably only two that may show up on your boards, and these are myasthenia gravis and Lambert-Eaton sometimes known as Lambert-Eaton myasthenic syndrome. But don't confuse the two. Of the two, the most common is myasthenia gravis. If you recall the normal physiology of the neuromuscular junction, first an action potential passes down a presynaptic neuron. As it approaches the end, it opens a voltage-gated calcium channel, which allows neurotransmitter vesicles to be released from the presynaptic neuron. What is the neurotransmitter in the neuromuscular junction? Acetylcholine. As acetylcholine makes it to the motor end plate on the postsynaptic muscle cell, it binds to acetylcholine receptors and triggers an action potential to propagate along the muscle fibers, leading to muscle contraction. Do you remember what two types of receptors are stimulated by acetylcholine? That's right, nicotinic and muscarinic. So what happens in myasthenia gravis? Patients have antibodies against the postsynaptic acetylcholine receptors, destroying them. This means that no matter how much stimulation comes from the nerve, it becomes very difficult to cause muscle contraction. These patients then end up presenting with difficulty contracting muscles that work very frequently, classically the eyelids and extraocular muscles, causing ptosis and diplopia. Generally, they may feel weak as well. What happens if patients continue to use the muscle, as in climbing the stairs? They have more and more difficulty using their muscles. If you think about it, this makes sense because the acetylcholine receptor is not responding to signals from the presynaptic neuron. And no matter how hard you try, you can't get levels of acetylcholine to increase enough to cause steady contractions. In terms of clinical vignettes, look for a patient, normally female, who complains of feeling weak and having trouble seeing, which gets progressively worse throughout the day. What should you be wary of in a patient that you feel confident has myasthenia gravis? Thymoma. What diagnostic test can you order to look for a thymoma? A chest x-ray or a CT scan. So how can we treat myasthenia gravis? Let's go back to the neuromuscular junction physiology. Normally, the acetylcholine that's released into the synaptic cleft is broken down by acetylcholine esterase relatively quickly. However, if you inhibit this enzyme, you can effectively increase levels of acetylcholine in the cleft and inadvertently drive more muscle contraction. This is exactly how you confirm the diagnosis of myasthenia gravis, by giving an acetylcholine esterase inhibitor called androphonium and seeing if the symptoms improve. One board's relevant fact is that both these syndromes have a paraneoplastic relationship with particular tumors. Myasthenia gravis tends to occur in patients with underlying thymomas. In contrast, patients with small cell lung cancer are more likely to develop Lambert-Eaton syndrome. So now let's talk about Lambert-Eaton syndrome. Here, the problem starts earlier than the acetylcholine receptor. Antibodies are formed against the presynaptic neuronal voltage-gated calcium channels. Therefore, when patients send a signal to contract, the action potential travels along the neuron, gets to these voltage-gated calcium channels, and causes them to open. But since they're impaired by the antibodies in Lambert-Eaton syndrome, only a small amount of calcium is able to enter the presynaptic neuron to allow for neurotransmitter release. What happens if not enough calcium is released? Then not enough neurotransmitter, acetylcholine, is released, and a weak contraction is elicited. However, unlike myasthenia gravis, if more and more attempts are made, more signals are sent, and so more calcium builds up in the presynaptic neuron. And so what happens to neurotransmitter release? More is more, and stronger contractions result. Contraction attempts, however, have to happen at a fairly rapid pace, otherwise the calcium will diffuse away and you won't get the benefit of the calcium buildup. What do you expect would happen if you gave someone with Lambert-Eaton syndrome androphonium? Not much. Their problem is not postsynaptic. Always, always look for small cell lung cancer in these patients. So which would you rather, myasthenia or Lambert-Eaton syndrome? I'd probably go with myasthenia gravis because there's a good treatment and thymoma is way less scary than small cell lung cancer. Let's have a flash quiz. Which disease is a presynaptic problem? LES or MG? The answer is Lambert-Eaton syndrome. Most commonly, myositis ossificans presents radiographically when calcium deposits are noticed within the muscles, often on the upper or lower extremities, and they have a sustained physical trauma. Myositis ossificans is important because you can easily confuse it with osteosarcoma in the clinic. As you see from the name of this fact, the name scleroderma is not as commonly used anymore, and actually has in part been replaced by the term systemic sclerosis. So what is scleroderma? You should think about this disease as a widespread, diffuse, uncontrolled deposition of collagen leading to fibrosis in the body. That, like most autoimmune diseases, affects women. The skin appears taut and puffy. Many organ systems are affected, including the skin, renal, pulmonary, cardiovascular, and GI systems, which is the primary cause of mortality. Look for this triad: autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. There are two major types that you should know about for your step 1. The first is called diffuse scleroderma. This is exactly what it sounds like, a widespread disease affecting skin and many other visceral organs, and it's rapidly progressive. What antibodies should you screen for? SCL70, or anti-DNA topoisomerase 1 antibody. Do you recall what topoisomerase 1 does? Relaxes supercoiled DNA by cutting one strand and then reannealing it. So what does topoisomerase 2 do? It cuts both strands of the supercoiled DNA helix simultaneously. The second type is a form of limited scleroderma, which affects certain areas more specifically. This is called Crest syndrome, and stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Usually these patients have fewer skin findings than people with diffuse disease, and if they do, tend to see it on their fingers and face. What antibodies should you look for here? The anti-centromere antibody. Remember, this presentation won't necessarily sound like scleroderma immediately, because there won't really be that many skin findings. Instead, there will be nonspecific skin findings on the fingers, some vague history of GERD, cold intolerance manifested by Raynaud's, and x-rays of the hands indicating calcium deposits under the skin. So which would you rather, type 1 or type 2 scleroderma? I bet you picked type 2, Crest syndrome, because it's more limited. What antibody indicates Crest syndrome? The anti-centromere antibody.